Okay, our next speaker could not make it because he could not get a visa, but he did supply a video presentation. So this is Hongxi Wang, and his talk is on evidence on best practices for teaching ophthalmology to medical students.
Thank you, Professor Carl and Professor Gabriela, for inviting me. It is my honor to share our thoughts about the evidence on the best practice for teaching ophthalmology. So good morning, everyone. I'm Hongxi Wang from Joint Shantou International Eye Center of Shantou University and the Chinese University of Hong Kong. There is no conflict of interest. We know that the evidence-based practice is an important idea for modern management, which is characteristic by the use of high-quality research in making decisions. The Center for Evidence-Based Management has proposed the 6A's process: asking, acquiring, appraising, aggregating, applying, and finally assessing. This process ensures that the decisions are made based on the most reliable and relevant information. So, how to use it to engage the best teaching practice? Firstly, you should ask unanswerable questions from the teaching issue. Various aspects within the learning ideology interact and contribute to the learning. So, is there any relationship among the factors? Does the teaching practice work? And remember, these questions should be learner-centered. A Chinese ophthalmologist might forget the initial process from unknown to known, so sometimes your questions might be just your wishful thinking. And after systematically searching for and retrieving the evidence according to the questions, we should critically judge the trustworthiness of the evidence. Traditionally, we grade the level of evidence by the study design, but the new pyramid with wavy lines indicated even for RCT, if poor designed, the evidence could be weak. And besides, the systematic review and meta-analysis become the lens through which the evidence is critically viewed. So there are some instruments for study quality assessment for reviewers or evidence-based practitioners. The most commonly used is the NIH tool, which is specific to certain study designs. For example, for controlled intervention study, there are 14 items for you to test the potential flaws and assess the risk of bias. Another tool called MERSQI is more specific to medical education research. You can also choose to apply. For example, we know that teaching ophthalmoscopy is very difficult. So is there any simulations tools or digital alternatives? You can search the keywords in PubMed, and you may be very happy to find this systematic review since it has completed acquiring and appraising. The authors found 20 relevant articles and summarized using 2 big tables. Then they used the NIH tool to assess the risk of bias and found most papers fail to consider randomization, blinding, and sample size calculation. Only 2 studies satisfy all NIH criteria, which are highly qualified and should be referred firstly. So let's have a look at this one. It is my work. You can further refer the methods that we illustrate in the article. See how to guide the students to assemble the smartphone ophthalmoscope using their own mobile phone, and then use it to visualize the retina for each other, and catch the image and record a video. Besides, we should also apply the evidence relevance and reliability. It is an RCT with a crossover design. In the first session, the Group A students were taught with traditional direct ophthalmoscopy, while Group B was taught using the smartphone. And in the second session, the training was closed over. This design allows both groups to receive almost the same intervention, which ensures the access and equality. Besides, we can use ANOVA to dissect the source of score variation. There should be a difference between the first and second session, and also difference between the group A and group B. After adjusting these factors, the remaining variation should be due to the tools. Therefore, the conclusion that the smartphone helps the medical student to view the retina more precisely is reliable. So after reviewing the literature, we pull the evidence together and make decisions. And this process requires the consideration of the other two dimensions, teaching experience and the student's value. Here lists some problem: the cost, the time. There was a global decline in ophthalmology course lengths over the last 2 decades, and most of our medical students won't specialize in ophthalmology. So are they worried? And recently, we conduct a systematic review on the topic about the use of the classroom in teaching ophthalmology to undergraduates. So some authors concerned about the students' preference and pressure, which also incorporate this finding when introducing the new teaching tool into implementation, or better to determine some specific suitable chapters for flipping. The teaching experience is also variable, although previous practice had heavily relying on it. Even so, we should make it more reliable. We can use the Delphi method to conduct structured surveys for expert panelism. Finally, a conversion outcome, consensus, checklist, or a standardized curriculum like this one shown here was made. After applying the teaching evidence, don't forget to assess the outcome. So we should do comparison better with controlled group. And the outcome measures contains not only the performance, but also the teacher and students' feedback and the long-term patient care effect. Here is another question, also focusing on the ophthalmoscopy. How to measure the capacity for undergraduates? Are the following instruments valid? So these questions depends on your objective. We know that completing the procedure step by step doesn't guarantee viewing the retina. However, requirement of giving diagnosis after ophthalmoscopy is challenging and not suitable for undergraduates. So, focusing on the visualization, we develop a simple eye model with some single letters on the folders. The students are asked to use the ophthalmoscope to view the model and view the pictures within 5 minutes. This task-oriented examination has been proven as moderately difficult and with high discrimination to differentiate between the poor and competent performers compared with the DOPS assessment. Finally, if there is few reported evidence, just conduct a study by yourself. We raise a Q-point mode to summarize the process of teaching study. Take our mock study as an example. Firstly, facing the declines in ophthalmology course over the years. Is there any resource facilitate the learning? We found MOOC was effective in other courses, so we constructed ophthalmology MOOC. But that's not all. We designed a research project and operate the experimental study, collect data from the students and found evidence. And afterward, the MOOC is open to the students as an online learning resources. This organized evidence-based teaching is now widely implemented in our university, college, and hospital. I would like to express my gratitude to the JSIEC teaching staff and students for their contribution. In conclusion, evidence-based practice in teaching ophthalmology requires critical and comprehensive thinking. By adhering to the 6A's process and taking consideration to the three dimensions and conducting experimental study using the Q-point mode, we can ensure that our teaching are effective and grounded in the best evidence. This approach benefits our students and contributes to the advancement of ophthalmology education. Thank you for your attention.